Hello, everyone, and welcome to part two of this lecture series on health information systems. Today, we'll be discussing problems, solutions, and implications drawing from the experience of the Philippine primary care studies. In the last talk, we described health information systems as electronic health records connecting to other electronic databases such as that of the pharmacy, laboratory, radiology lab, and even the financing system. We also described the role of the health information system in facilitating governance of universal healthcare. We discussed how it helps with workforce development through development of a health human resource map and development of a platform for continuing training. The HIS also helps in developing the healthcare provider network through generating an inventory of facilities and mapping them out for decision makers. It also helps financing through expense monitoring and can thereby help control abuse and possibly even fraud. The HIS also facilitates community engagement by providing a place where we can store patient education material and providing a potential venue for patient communication, which is text messaging through their cellular numbers. Finally, the health information system can help us keep track of performance measures, whether they pertain to patient outcomes, healthcare worker outcomes, or administrative outcomes. It cannot be stressed enough that these are just potential uses of a health information system. There are just too many problems that need to be anticipated and solved. So the objective of this talk today is to highlight potential problems that will be encountered in setting up a health information system, to propose possible solutions for these problems, and to demonstrate implications when these problems are not solved. And these three define the three parts of my talk: potential problems, possible solutions, and implications. So let's get started with the potential problems. PPCS encountered problems in three general areas of the health information system. Problems with the hardware, the different appliances that will be used for the health information system. Problems with the software, the different programs that will be installed in this hardware. And problems with the network, the system of cables and Wi-Fi connectors that are needed so that the different systems interact with each other and can connect to the internet. So what are these potential problems? For hardware, the first problem is this: senescence. This used to be a brand new, good-looking computer for those of you who are aged 60 or more. But things get outdated quickly, and new equipment can become old very soon. Another problem is theft. Believe it or not, our first 2 or 3 dozen computers, a few were stolen even before we could install them. For software problems, there were problems with these: bugs, which we encountered almost every day and had to work on very closely. We also had problems with technophobia. Healthcare workers, many of them, are afraid that the health information system represents additional work for them and will only make their work harder. Finally, there are problems with the network. Connection problems having to do with router maintenance and internet access. And this can come at very inopportune times when you least need the problem, when you're busiest in the middle of work. What are the potential solutions? For senescence, we found that outsourcing our equipment was the easiest solution. Outsourced providers can guarantee repairs and replacements of equipment, which is especially important when you're in the middle of work. Theft can be solved through engagement of the community. Here we had very interesting solutions. It's not enough to put your computer on a desk. Whether it's a laptop or a desktop, you need to keep it secure. One of the things we needed to do to prevent further theft of the computers we bought was to put these cables which attach the computer to the desk. We also made sure that when not in use, the computers could be stored in the drawers with lock and key. In many centers, including the barangays, we had to make sure that the doors could be secured as well as the windows. Community members advised us to put signs. And here's an example of what we put. Ang PhilHealth benefits natin ay nakasalalay sa mga computer na ito. Pangalagaan po nating lahat. This engages the community and makes them part of the protection of the hardware. In addition, they recommended putting religious figures around the computers to discourage theft, which I thought was a brilliant idea. And once we implemented these measures, no more computers were stolen in the next 3 years. For debugging and development, I think the best solution, again, is to outsource. Believe me, this is not something you want to put on the shoulders of your workforce, unless you are a computer company. Development is almost endless, and debugging is even more difficult because there will always be problems coming up. Rather than you being the ones to solve these problems yourselves, you'd like to be able to call someone else. Technophobia was simply solved by making computer entries a requirement. So, if you don't put ICD codes for your diagnosis, patients wouldn't be able to avail of benefits, and it was left up to the healthcare worker to explain why they couldn't avail of these benefits. If you don't use formulary codings, then prescriptions are not filled. And if laboratory requests aren't filled up using the required forms, then these again need to be paid for out of pocket. Network and router maintenance, again, can be outsourced. Outsourcing is simply a convenient solution for many of the problems you'll have with the health information system. Perhaps the biggest problem we encountered had to do with internet access. In our site in Samal, Bataan, there was a population of 38,000, and we were able to connect all 14 barangays. For this, we used long-distance routers attached on towers held up by guy wires. This was very convenient in Bataan because many of the barangays were within line of vision from the rural health unit. So the connection was very good. In Bulusan, Sorsogon, however, with a population of 24,000, we were only able to connect 6 of the 24 barangay health stations. This was because of the huge mountains and dense forests that surrounded Bulusan. This had many implications, and I'll show you some of them later. It's not a problem unique to Bulusan. This is a national problem. Recent studies show that more than 60% of our countrymen have poor internet connection or no connection at all. And the condition is worse in underserved areas. One potential solution to this problem is satellite access, because satellites can be accessed across mountains, forests, and other terrain. As of the latest count, there are at least 3,000 low Earth orbit satellites around the Earth that can provide these internet services, and we have access to a few of them. The problem is that an old executive order, as old as the 90s, allows only telecommunication franchises to provide internet access. This led us to lobby for an executive order to revise the old one. And this was signed by President Duterte in March of 2021. Executive Order 127 liberalizes access to satellite services and allows providers other than the telecommunication franchises to provide internet service using satellite. We hope that many LGUs will take advantage of this EO in the coming months and years, because we really need to connect all sectors. And that brings us to what happens if we can't. What are the implications of failing to develop our health information system? Let me share some things that happened in the Philippine primary care studies. This is a graph of the cumulative consults during a one-year period. In our rural site, there were 74,743 consults, but in our remote site, there were only 23,265 consults. If you look at individuals, the rural site was able to enroll almost half its population in just a year, while the remote site was only able to register about 1/4 of the population. Here are some reasons why. One reason was the greater ability to conduct telemedicine consults in our rural area. Note, 3,985 telemedicine consults in just a year compared to 575 in an area where there was poor connection. A second reason had to do with our ability to activate the barangay health stations. There were computers connected in all the barangays, if you remember, in our rural site, and therefore during that 1-year period, there were up to 6,205 consults in these different barangays. Compare that with our poorly connected remote area where there were only 52 consultations at the barangay level. This had implications in terms of access to service. We conducted detailed costing of healthcare services in all our sites, and if you look at the rural, remote, and urban site, the capacity to spend was highest at the rural site. A total of 836 pesos and 65 centavos per capita was spent per year. The remote side had a lower capacity to spend, and it was about equal in the urban side. If you break down these healthcare expenses into how much came out of pocket, you'll see that in our rural site, it was 153 pesos, which comprised 18% of the total healthcare expense. So they only paid 18% from out of their own pockets. In contrast, in our remote site, despite the lower capacity to spend, patients were spending more per capita per year, 371 pesos, or 53% coming from out of pocket. This is a clear case of aggravated inequity, where people who need it more are able to use health services less. Of course, in our urban area, out-of-pocket expenses accounted for 54% of outpatient healthcare costs. But this is expected in an urban area where people would rather access other healthcare providers. So in summary, I've talked about potential problems that we may encounter in developing our health information systems and talked about possible solutions. These are very important to address because failure to develop our health information system has dire implications. We should remember that the main beneficiary of our health information system is the patient. And we want to be able to render not just effective and efficient care, we want equitable care, walang iwanan. And that means connecting everyone, not just those near the provincial center or the municipalities, but those in the barangays, including far-flung communities. We hope these 2 lectures give you an idea of how to make data-driven development a reality in this country. Maraming salamat po sa inyong pagkinig.